Well, good morning, everyone. This is Ron Gibbs. I'm having the pleasure of moderating our session, COVID in the Maternal-Fetal Dyad. Of course, we're dealing with the COVID pandemic, the #1 news story of the year and the #1 medical story of a century. And this morning's panel consists of national experts. You've already been introduced to them, but let me briefly reintroduce you. So Dr. Bonnie Maldonado is Senior Associate Dean for Faculty Development and Diversity and the Taub Professor of Global Health and Professor of Pediatrics Infectious Diseases at Stanford. Grace Lee is also Professor of Pediatrics Infectious Diseases at Stanford. And Dr. Christina Hahn is Associate Professor at UCLA, MFM Division Director and Fellowship Director. So we'll get right to it. We have a number of questions to feed to the panel, and then we'll have time for questions from the field to follow. So the first question is, what's going on? What's the overview as of today with the COVID pandemic, particularly with vaccines and the variants? Bonnie, would you mind leading off on that?
Yeah, let me go ahead and start if I can get the first slide, please. So yes, I wanted to give you just an overview of cases, deaths, a bit around vaccinated individuals and variants. I will leave for later in more details if people have questions about the vaccines, but next slide, please. So if we look overall, and again, these slides are a little older because I had to submit them last week. So we know that overall the worldwide new cases per day are the highest they've been throughout the pandemic in the last month or so. So this pandemic has not gotten better. It's actually really spreading around the world. However, we are starting to see a recent decline. You can see there in this graph that we've seen a little bit of a blip back in April, another one in July, a big bump worldwide between November, dropping off in February substantially. And now we're seeing a bigger bump up April through May, but we may be seeing a reduction there. That may reflect issues around variants and new transmissions. It may also reflect secondary spread, but there's around the world, there are many different reasons for this increase, but it is happening nonetheless. So we are seeing overall 158 million cases around the world with 3.3 million deaths. It's really a devastating toll in a period of less than 16 months. Next slide, please. Now, if you see the data tracker for the United States above, this was from a few days ago from CDC. We are currently seeing in the United States almost 33 million cases reported with about 580,000 deaths in the United States. And you can see here the little surges that we have compared to the overall surges in the world are very similar. That is, we had our first surge in the US in April. The peak occurred right in the middle of early to mid-April. The second peak was over our summer in July. And then we had the really overwhelming major surge that we experienced from end of October through the beginning of February. And we did experience another surge in early spring, but that appears to be dropping off pretty substantially. So we are currently now, we have a total, as I mentioned to you, of over 30 million cases with 500,000 deaths. But in California, because we are regional, we're seeing about 3.7 million cases with about 60,000 deaths. And again, the numbers are low in California. What we're seeing is that we have the lowest positivity rate in the country. We are seeing a real reduction overall, even in our hotspots, including the Central Valley, Southern California, and not so much in the Bay Area, but we are seeing all of our areas starting to move down into lower and lower tiers of concern. And as you saw, we are, several of our counties are now quote unquote the yellow tier, which is the most permissive tier. Next slide, please. Now, I'm just going to go over very high level vaccination. So as you know, we have 3 vaccines approved in the United States for emergency use of 2 mRNA vaccines, one produced by Pfizer, one produced by Moderna, and then the 3rd vaccine is an adenovirus vector platform vaccine developed by Johnson & Johnson and Janssen. And you can see down below on the lower right, the proportion of vaccines that are given for each of those. And so you can see that in the US, we have provided over 100 million doses of both of the Pfizer and Moderna vaccines each. So we have experience with over 200 million doses of the mRNA vaccines. And because the Johnson & Johnson vaccine was more recently approved, that vaccine, we're seeing about just under 20 million doses that have been administered in the US. And you can see at the top, with assuming a population of 328 million, which we know from the recent census is a little low, but let's just use that number. We've seen that about almost 150 million people have received at least 1 dose, with 106 million people fully vaccinated, representing 32, almost over 30%, over a third of the US population. When you look at the population over 18 years of age, the number of vaccinations represents 40% of the population who are fully vaccinated, and 56% that have at least received 1 dose. And when you look at populations over 65, greater than or equal to 65, it is really encouraging to see that in that population, over 80% of that population has received at least 1 dose of vaccine, and about 3/4 of that population is fully vaccinated. So we're really encouraged by the numbers that we're seeing in the US. Next slide, please. And then finally, I just wanted to mention that we are seeing this evolution of the virus. We expect viruses to mutate. That is what they do. RNA viruses in particular, which SARS-CoV-2 is an RNA virus, will mutate a little more rapidly than DNA viruses for a number of structural reasons. But this virus has mutated as it's moved through populations. And in particular, what we are tracking is the mutation of the spike protein. Now that's because the spike protein is the protein that the virus uses to attach to the ACE2, which is a protein on the surface of human cells, and that serves as a receptor for the virus. And so mutations around the receptor, the spike protein, can actually lead to less or more attachment affinity to the host human cell. And what we're seeing now is we are starting to track what we call variants of interest, variants of concern, and variants of consequence. And these are just variants that we think are mutations in the spike protein that lead to more, what we think is more likely attachment to the host cell, and therefore potentially more transmissible. And what we're seeing now is a variant in the peach color, which is the B117 variant. And that variant was initially identified by the National Health Service in the United Kingdom. So it's called the UK variant now, informally. That variant is highly transmissible. It's about 50% more transmissible than the original Wuhan strain. And we are seeing now in the US, when you look back from January through April of this year in the US, that it is making up the majority of the viruses in this country. But we are seeing other variants as well that are apparently not as transmissible as the B117. There may be other variants that will come along that could be as transmissible or more than the B117, but we haven't had the opportunity to collect all those data yet. Now, what is reassuring are 3 things. One is this variant does not seem to be more severe in the US compared to other viruses, other SARS-CoV-2 viruses. There were some initial reports in the UK that it might be more severe, but frankly, those data were probably not epidemiologically not really as sound in terms of identifying the population at risk. So we think that they tended to over select for people with risk for severe disease. In the US, we have not seen that it causes more severe disease. That's one important point. The second important point is that we are seeing that the viruses are not, that are, all of these variants are still neutralized in the real world by vaccines. So if we have been vaccinated, we're not seeing that people are disproportionately getting reinfected or having breakthrough infections with any of these variants. And third, what we're seeing is that the neutralizing antibodies, so in the laboratory, we're seeing that although the variants, some of these variants may have a reduced response to neutralizing antibody induced by vaccines, they are still responding to that antibody so far. So we're very fortunate, but this is why there is a race to make sure that we get enough people vaccinated so that we can stop transmission, because transmission was what creates new mutations as the virus replicates in new human hosts. So I will stop there and hand it back off to you, Ron.
Bonnie, thanks for encapsulating where we are really up to the minute. So that's the story in the general population. And now we want to look at the impact of COVID in the mother and then the fetus and newborn. So Christina, would you lead us off about the interaction of COVID-19 and pregnancy?
Wonderful. Thank you so much for that introduction, and thank you to the conference organizers for the invitation. What an honor it is to sit alongside Dr. Maldonado and Dr. Lee. So I was charged with distilling the risks of pregnancy down into 5 minutes, which is simultaneously an easy task and implausible. It's easy because I'm assuming everyone sitting here already knows and understands the dangers of COVID in the maternal-fetal dyad, but difficult because just in the last year, we've had 2,000 plus publications on COVID in pregnancy. So let me advance the slide here. So what I decided to start off with is to sort of go over the 10,000 foot view to show how far our pendulum has swung in the last year and really how mercurial our counseling has been over these last 12 months. So back in March 2020, when all of us were returning from Society for Maternal-Fetal Medicine's annual meeting and starting to note these strange cases of very sick women, what we had heard coming out of China was that there was no increased risk for pregnant populations, with the exception of maybe some iatrogenic preterm delivery. Please advance. Then by April 2020, interestingly, the CDC very quickly decided to remove pregnancy from the high-risk category based on some of these really preliminary case series. Advance. And then we move forward to June, and at that point, the first MMWR came out from the CDC, which showed that there was some increased risk for ICU admission, for a need for mechanical ventilation in pregnant women, and for the risk of death maybe not being affected. So we were seeing some maybe slight increases by that point. Advance. And then by November, we really started seeing some higher numbers. At this point, we realized that more pregnant women were ending up in the ICU, again, mechanical ventilation, increased risk for ECMO, and then increased risk for death. Next slide, please. So this slide then takes the data from the Maternal Fetal Medicine Unit Network, which was 1,200 patients across 33 hospitals, and asked what was the percentage of pregnant patients with COVID that we expect to become ill. And what we have in these first two parts of the pie chart that you see here are the asymptomatic patients, of which 47% were, and the polysymptomatics of very mild symptoms. And so that showed that 3/4 of pregnant patients who were being tested and found to be positive were of no real consequence clinically. Advance. Now, if we take the remainder of this pie chart and break that down to moderate, severe, critical, and mortality, what we see is that 14% of patients presented by the MFMU were of the moderate category, 8% were severe, 4% critical, and a small percentage did unfortunately demise, and that's 0.3% in this cohort. Advance, please. And altogether, that adds up to the remaining 1/4. Next slide. So I apologize that this ended up a little bit smaller in the combined version of our slides, but what we ask here then is, for those patients who are found to have COVID in pregnancy, what sort of symptoms were they presenting with? And this was from one of the largest systematic reviews and meta-analyses that came out in the late summer of last year. And what they saw, advance please, was that the highest proportion of symptoms that patients were presenting were fever, chills, an increased leukocytosis, lymphopenia, and an elevated CRP. Now, this very much matched the non-pregnant population, with perhaps these percentages being just a tad bit lower. And the reason for this was that, as many of you know, obstetrical units started doing universal screening. And that really was one of the first populations where we were doing broad stroke screening of everyone with or without symptoms. And that therefore led to more patients who were asymptomatic carriers being included in these cohorts. Next slide, please. So then what this meta-analysis also noted, as I mentioned, was that compared to the non-pregnant population, only a much lower percentage were showing up with these fevers, dyspnea, and myalgia symptoms. And again, this big asterisk is to show that the denominator really is different. And so you can't really compare these two groups. Next slide, please. All right, so this is where we start asking, what are the outcomes when a pregnant woman presents with COVID? And so the first set of data presented here are the COVID-related symptoms. And I've demarcated the highest proportion of patients that were reported in this series. And what we show is that 10% of patients had a severe COVID out of this really large systematic review. And that matched up to what the MFMU report said. And then of this cohort, 22% had oxygen requirements and 35% presented with pneumonia. However, what's more important in this slide is actually the more rare of complications. Please advance. And so what we see here is that 4% of patients were admitted to the ICU, 3% required invasive ventilation, but a very low percentage required ECMO. Next slide, please. So this next table compares pregnant and non-pregnant individuals with COVID. This red box is around the 3 outcomes with the most statistical significance, which were the odds ratios of 2.1 for ICU admission, 3.6 for invasive ventilation, and 2 for ECMO. However, both of these last 2 slides and the MMWR report, what they were comparing was really apples and oranges, because the question for us isn't really what happens when a COVID positive patient becomes pregnant. So advance to the next slide. The actual important question to us as obstetricians is what happens when a pregnant patient gets COVID, not the other way around. And so this is the really striking data that we should be using when we counsel our pregnant patients about what can happen. And what we see here is an odds ratio of 2.9 for mortality and 18 for ICU admissions. So when a pregnant patient gets COVID, compared to the non-pregnant individual, they are 18 times more likely to end up in the ICU. And then that brings us to the obstetrical complication, the first of these being mentioned, and that's preterm birth. And that's an odds ratio of 1.5. Please advance to the next slide. So now we dive into the pregnancy-related complications. So the preterm birth that I just mentioned was reported in 17% of the population. And just as a reminder, I know we have international participants, but in the United States, our preterm birth rates are typically quoted around 9 to 10%, with California, interestingly, thanks to CMQCC, being one of the lower risk states. But this is definitely an increase from our background risk. The rates of cesarean delivery, you'll see lower down here, followed by the vaginal delivery in the next line, were also elevated at 54%. And so this may have been due to some of the early reports coming from international sources that where all patients were being delivered by section due to our concern of their ability to tolerate labor with their pulmonary complications. Advance the next slide, please. Now we move on to the offspring outcomes, so the fetal part. In terms of the offspring outcomes, 33% of neonates were admitted to the ICU, and that's definitely an increase from background. And like before, these rare outcomes on the left are where the significant differences are seen. And what you'll see here reported in this first line is that 72 cases out of the 9,000 neonates that were included experienced stillbirth, and that's an increase from our baseline expectation. Next slide, please. And so that leads to an odds ratio. Again, we are comparing pregnant individuals with COVID to pregnant individuals without COVID. And what we see is an increase in stillbirth with an odds ratio of 2.8 and an increase in NICU admissions with an odds ratio of 4.9. Next slide, please. So then how do we determine who is at the highest risk? Which of our patients will end up in the cohort with complications? And I've divided these into 3 buckets: the demographics, the comorbidities, and the exposures. Very similar to the non-pregnant population. What we see is that anyone with any of the comorbidities in this middle bucket, that's obesity, diabetes, immunocompromised state, including cancers and medications and transplants, chronic hypertension, renal disease, underlying lung disease or heart disease, and sickle cell anemia, all of these patients were at increased risk of complications. For the demographic side, we knew that African American and Hispanic, Native American, and Asian Pacific Islander populations were more severely affected, and this was reflected also in the obstetrical population. What we saw was advanced maternal age did impact outcomes. And then from the exposure side, smokers and healthcare workers, possibly due to a higher dosage of viral transmission at the time of their infection, were presenting with more severe disease. Next slide, please. So that brings us to the question of why does COVID increase the rate of stillbirth? And there's still a lot of work being done in this. But this is a slide I really like, published in January of this year, that took a series of studies where placental outcomes were evaluated and broke them down based on what findings were found histologically and on gross specimen evaluation. This little red sliver at 12 o'clock is the only group that had normal placenta. And so 2% of patients presenting with COVID in pregnancy had normal placental findings. The largest group of complications were the maternal vascular malperfusion section, and those included increased fibrin deposition, increased infarction, decidual vasculopathy. The next group was the group with inflammation, and that made sense. When we have systemic inflammatory response occurring, the same will occur in the placenta with decidulitis, velitis, and intervillositis. And then the last of the designated complications is the fetal vascular malperfusion section. And that included avascular villi, delayed villus maturation, chorioangiosis. And then there was this broad group of others, which included meconium staining. And so what we see is that COVID is absolutely affecting placental function and placental histology. And that possibly is what's translating to the increased risk of stillbirth and NICU admissions. Next slide, please. And the last question we'll ask for this section is, what about vertical transmission? So we know very well from data on other viral illnesses that the rate of vertical transmission is quite broad. In some viruses, such as parvovirus, the rate of transmission is as high as 1 in 3. In others, such as CMV and varicella, depending on where you are in the pregnancy, the rates could be below 1%. But we do know that vertical transmission has been reported in essentially all viruses. What we see here in this other systematic review and meta-analysis is that when neonates are swabbed immediately at birth, 3% of neonates were presenting with positive nasopharyngeal swabs. And this indicates that there is some transmission that is happening, whether it's at the time of delivery versus at the in utero. That remains to be determined. We also see that placental swabs yielded positive COVID PCR results in 7%, and in cord blood, SARS-CoV-2 has been found in about 3%. And interestingly, this is the one argument that folks have against vertical transmission is that amniotic fluid continues to remain without any evidence of viral transmission.
Christina?
Uh-huh.
Yep. We've got a lot to cover, and we're going to save the vaccine part for a separate question.
Okay, perfect.
Okay.
So we'll stop here and move on to the next section.
Good. So thanks very much for that very thorough review. Now we'll look at the impact of COVID in children, and in particular with the MISC. Bonnie, are you going to head us up on that?
Yes, please. Thank you so much for your attention around this too. So I will be brief. I just want to make a point that there at the bottom, on the bottom right, you can always go to aap.org, which is the American Academy of Pediatrics site. And I have to say that the Academy has really provided virtually all of the data on children in the country. So it's a great website to go to. There are a lot of resources and toolkits there for people to look at. And they started putting these data together at the end of 2020, and it's been very helpful to see this. So as an overview, you can see that it doesn't, I don't have the number of kids here. We've almost 3.8 million children now have been infected. And of course that number is cumulative, so it's gonna go up over time. Children represent almost 15% of all cases, and about 5% of children in the US population on average are infected, or that is a rate of about 5,000 per 100,000 kids. And more recently, they are representing almost a quarter of all new weekly cases. Now, again, we know that the numbers are dropping off overall, but children are representing more of those cases. When you look at testing, children are making up between 6 and 20% of total tests, and about 5 to 30% of children are testing positive. Around hospitalizations, there are, I don't have the number here, unfortunately, it fell off of my slide, but there are a few thousand hospitalizations now reported in the US in children, but they represent between 1 to 3% of all reported hospitalizations for the US, with about 0.1 to 2% of all children who have COVID being hospitalized. So it's a very low rate. And the mortality for the last report, there will be a report coming out in the next day or so from the AP, they update every 2 weeks, is about 300 children so far who have died in the US. And there are estimates from other models suggesting that up to 600 children may have died from COVID disease, which represent a really extremely low fraction of overall deaths, with 10 states reporting no deaths, and very, very few children with cases actually resulting in a death, as we indicated there. Can I get the next slide, please? Common symptoms, and you'll have these slides I hope to look at later, but there was a study looking at comparison of symptoms between children and adults. And what we see overall is that the most common symptoms in children are very similar to those in adults. That is fever, cough, and shortness of breath, but they also have headaches and vomiting as well. But all of the symptoms in general are less commonly reported than among adults. Next slide, please. One important point that I think we need to stress is that the majority of children who are hospitalized, children under 18 who are hospitalized with COVID-19, had an underlying condition. That is obesity being the most common at almost 40% of hospitalized children, asthma, and then immunocompromised children, with other factors accounting for much less than 5%. Now, the other important point to remember is sometimes, as we know, we are testing children before they come into the hospital because we're testing everybody. So COVID may be an incidental finding, and there are papers that are going to be coming out pretty soon. Actually, one from Stanford, not with me as an author, but others at Stanford looking at this and finding that trying to separate out the kids who are incidentally infected with those who have COVID symptoms. But remember that underlying conditions are still important in children. Next slide, please. I'm going to just talk briefly with the next 3 brief slides about MISC, just mentioning that there is a case definition for MISC. It's very specific. Children and people under 21 with a fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with organ system involvement. So the definition itself includes people who are hospitalized with no alternative plausible diagnosis and a recent or current evidence of SARS-CoV-2 infection, either by PCR or serology. And so if we can go to the next slide, I can show you that, in fact, there are 3 classes of patients that we're starting to see. in the US that fall into this MISC category. And class 1 are older children generally. They tend to have typical MISC, 98% are serology positive, with very few being PCR positive. So evidence of maybe an inflammatory response to a previous infection. 100% had cardiovascular and 98% had GI manifestations, very elevated inflammatory markers, and a high percentage of ICU admissions. Class 2 being a mix of acute COVID with MISC. All of these were PCR positive as opposed to class 1, with only a few being serology positive at 16%, more respiratory involvement, and a somewhat lower ICU admission, but still over 50%. Then class 3 are milder illness. These children tend to be younger, about median of 6 years of age, with a higher frequency of exanthem and enanthema, with 97% serology positive, a third are PCR positive, and 44% ICU admissions. And then my last slide is really to just show you what the number of cases are in the US reported by CDC. And you can see in the map here, the darker the color, the more the number of cases. This is not adjusted for population size. These are just raw numbers. So we've seen so far reported as of a couple of weeks ago, a little over 3,000 cases with 36 deaths. 47 states, New York City, Washington, D.C. have reported at least one case. The average age is 8 years, 57% male, with a third being Hispanic or Latinx, 30% Black, non-Hispanic. So really disproportionately affecting our children of color in this country. And I'll stop there. Thank you so much.
Bonnie, thank you for so nicely encapsulating the story. So now that we know the background in pregnancy and in children, we want to go to vaccines. And let's take a look at vaccines in pregnancy. There's an article in the New York Times just this morning about 2 articles that appeared yesterday. So this is going to be fielded by Christina and by Grace. Christina, are you going to go first?
That's what the slides are. Happy to go
first. Grace is standing ready.
So Dr. Lee is going to be talking about the safety of it. I'm going to be talking about why this works. So just in general, this is the same way I counsel patients. The first question is, how do we know that vaccines work in pregnancy? And this is a cross-section of the placental villi. We know that antibodies are able to cross through because there are receptors on the syncytial trophoblast that basically carry the antibodies through to the fetal circulation. And so this is how I typically start my counseling, just based on the decades of data we have. Next slide, please. So then the next question is, how do these antibody transfer change across the pregnancy? And when should I be getting my vaccine so that I develop the right amount of antibodies? And so this is really some foundational work from the 1990s that tracked antibody levels in cord blood, obtained either from chordocentesis or at delivery. And what it shows is that antibody transfer does increase across gestation, with levels in the second trimester at about 5 to 10% of maternal levels. And by term, the neonatal and fetal antibody levels are actually higher than maternal antibodies. So we know that there is preferential transfer that's happening. Next slide, please. And so don't be daunted by this table. We're going to kind of go over this data from Edlow's group in Boston. This is one of the first big studies that tracked women and lactating individuals who were had received the COVID vaccines to see if antibodies were getting through the way that we expected it to. So in these violin plots, what we have on the x-axis are V0, V1, and V2, and that is the day of the first vaccine, so pre-vaccine for V0. V1 is dose number 2, and V2 is 2 to 3 weeks following the vaccine. And in each of these time points, there's 3 different plots. So we have the non-pregnant individual, the pregnant individual, and the lactating individual. And what you see on the y-axis is the antibody response in the top row to the spike protein that Dr. Maldonado mentioned earlier. And in the bottom row, the receptor binding domain of the spike protein that really is the most consequential of the part of the protein. And so what you see across all of these graphs is that pregnant, non-pregnant, lactating, it doesn't matter. Your antibody response seems to be the same. On the top right in graph E, what we have are the IgA, IgG, and IgM responses. And the two that flatten from time point V1 to V2 are the IgA and IgM as we expect. And the IgG continues to increase as we expect it to. So this is all really following the science that we know. Now, this bottom right graph is something that I really like to mention to patients who've had prior COVID natural infections. The fourth violin that's been added on here is the natural infection group. And what you see is that those who receive the vaccine have a much more robust response than the natural infection group. Next slide, please. And so in this slide, we switch over to the lactating individuals. And in the same way that we asked, how do the antibodies cross through the placenta? We have data that shows repeatedly that IgA antibodies are able to cross the mammary epithelial cells to get into the alveolar lumen where the milk is waiting. And that IgA being consumed by a neonate is what protects all the mucosal membranes. Next slide, please. And so in this slide, what we are talking about is the breast milk content of IgA antibodies. And the same time points from V0, V1, V2, you see that the response does increase over time and that it is getting through to the antibodies. And so this is essentially the counseling that I go through with all of my pregnant individuals and lactating individuals, that we know that antibodies work. We have had decades of data that we know that antibodies are being produced the way they should in the same way as non-pregnant individuals, and that they are getting through to protect neonates and mothers, and that this is indeed protecting our obstetric population. And with that, I'll turn this over to Dr. Lee.
Christina, thanks. That's wonderfully encouraging. Grace is a member of ACIP, so here we go.
Thank you. I'm just going to focus in on the safety component. You can skip to the next slide. I have no financial disclosures. This is just a reminder, brief reminder, that with regard to vaccine development and prior to a recommendation being made, there are actually 3 checkpoints for safety. The first being data safety monitoring boards for clinical trials. The second being a federal advisory committee called VRBPAC that advises the commissioner of the FDA on the regulatory use of vaccines. And then the Advisory Committee on Immunization Practices that I sit on advises the director of the CDC on recommendations for use of the vaccine in the US civilian population. Both of the last 2 are federal advisory committees. Next slide. And as part of ACIP, I actually chair the COVID-19 Vaccine Safety Technical Work Group, or we call it VAST for short. This work group was convened specifically for COVID-19 vaccines so that we could review, evaluate, and interpret all of the post-authorization data coming in from various vaccine safety surveillance systems. This is a central hub for our technical subject matter expertise from federal agencies conducting post-approval safety monitoring. We advise on analyses, interpretation, and data presentation, and our role is to provide updates to the ACIP COVID-19 vaccines work group and the full ACIP. And the reason it's important to mention it's a federal advisory committee is because all of these meetings are open and public on COVID-19 vaccine safety. Next slide. I just wanted to remark, and Bonnie mentioned this, we are now 262 million doses into the US vaccination program, and 153 million individuals who have received at least 1 dose. So we actually, to date, have had a tremendous amount of safety data. Next slide. VAST, our activities, we have been meeting nonstop weekly. So we've actually had 14 meetings prior to the authorization of any vaccines to prepare for vaccine safety surveillance. And since the first vaccine was used in the United States on December 14th, 1 week after we began meeting, and we have been meeting at least weekly, we've had 20 independent meetings to review the vaccine safety data and 4 joint meetings with our COVID vaccines work group focused on safety. And you'll see there the timeline over the past 5 months, all the activities that have happened at ACIP. Next slide. Oh, yeah. I will just mention on this slide that these are the vaccine safety surveillance systems that are contributing to the data in the post-approval phase in the US. We knew early on that because of the way vaccines have been allocated, and also just because of the way rollout goes, that we would be relying early on 3 systems, one called vSafe. I'll tell you a little bit more about that in a moment. The second called VAERS, which is a long-standing passive vaccine safety surveillance system in the US. And the third is called CISA, which provides individual case consults, and they have been tremendously helpful for us in that they have essentially provided real-time consultation services to clinicians who have clinical questions that aren't addressed by the CDC or ACIP guidance. We also later in the program, and now we are later in the program, have relied more on our large linked database monitoring programs. The reason those are important is because those tend to be closed or population-based surveillance systems. So for example, the Vaccine Safety Data Link, heavily based in California, follows individuals at a variety of Kaisers and a few other sites across the country that allow us to understand rates of potential adverse events. FDA has a partnership with CMS, the VA has been contributing data, the DoD and IHS have also contributed data. I just want to mention one thing here, which is on the VAERS front, the role is really to do early detection or early warning system for the country. In the first weeks after vaccination, VAERS is what we use to detect the anaphylaxis signal that we heard about from the UK early on. And then more recently, I just need to mention that with the J&J or the Janssen vaccine, there was a safety pause initiated because of cases out of VAERS. And then ACIP met and reconvened to review the risk assessment and the benefit risk assessment. But I did want to mention in particular to this group of providers on the phone call that the Janssen vaccine the recommendation was reaffirmed from a population perspective with a warning for women 18 to 49 years of age of the increased risk of thrombosis with thrombocytopenia syndrome. That risk seems to be highest in this 18 to 49-year-old female population, which happens to be the population that many of you serve. So I just want to make sure that you're aware of that. And if you have any questions, please let us know. There are alternative vaccines available clearly. Next slide. vSafe is a really interesting system that they stood up for COVID. It's a text messaging based system that does initially daily check-ins, then weekly, then quarterly check-ins for individuals to really monitor the health impact of vaccines. You'll see here that as a side product of this, there was an overwhelming response from pregnant women who chose to receive vaccine. As you recall, when the vaccines first came out, ACOG and SMFM really made the statement that they understood, pregnant women were at high risk for severe complications, and that, while we always want more trial data, we didn't want to delay access to vaccines for women who are pregnant, and so that it should be an option for those individuals. If you go to the next slide, I think. Oh, it won't be here, but I'll tell you about it in a second. So here, this just shows you some of the reactogenicity data from vSafe, demonstrating that for both Pfizer and Moderna, local and systemic reactions are common as we anticipated. Next slide. And they're very similar for the two. And that dose 2 tends to be more reactogenic than dose 1, which we knew from the clinical trials. Next slide. But what happened was there were over 100,000 women in the US that actually reported that they were pregnant into the vSafe registry. So the vSafe team actually created a standalone independent registry where now they're initiating outreach to those who report that they are pregnant following COVID-19 vaccination. And they're actually encouraging them and recruiting them to enter into this COVID-19 vaccine pregnancy registry, which is looking at the health impact on both pregnant women and their infants. And you'll see here, the opportunity to be able to follow for a longer period of time. Next slide. Up to date, as of May 10th, they were able to enroll close to 5,000 women in the vSafe COVID vaccine pregnancy registry. But clearly you can see now 110,000 women who've reported in that they're pregnant. And so they will continue to work on this, but this was sort of an innovation that they added in response to the robust response and participation from pregnant women. Next slide. In terms of reactogenicity in pregnancy, this was published by our colleagues from the CDC and the New England Journal of Medicine. What you'll note here is that for Pfizer and Moderna, dose 1 and dose 2, it's as you would anticipate in terms of local and systemic reactions, perhaps slightly more local reactions in pregnant women, but not substantially more so. And then slightly fewer systemic reactions reported in pregnant women compared to non-pregnant individuals. But again, nothing substantially different. Next slide. Importantly, of the ones that had completed their pregnancies, they are asking these questions. And so specifically looking at, for example, in the pregnancy registry, what is the rate of spontaneous abortion or stillbirth reported? And you'll see here on the right column that it's 12.6% and 0.1%. And so comparing that to published incidence of these pregnancy outcomes, it looks like it is within range of what is anticipated or expected during a normal pregnancy with or without COVID. Actually, I should say without COVID, since Dr. Hahn just mentioned the differences with COVID. And then in terms of the neonatal outcomes, you'll see here again, preterm birth rates, 9.4%. And Dr. Hahn mentioned sort of the baseline across the country is the about 9 to 10%. So right there in that range. So really, in terms of pregnancy outcomes and natal outcomes to date, it's been really reassuring that there hasn't been any imbalance in data that we are seeing to date, but we will continue to monitor this going forward. And I should also just mention that as part of the vast work group that we do have, we do meet monthly with pregnancy experts specifically to review the pregnancy data to ensure the safety in pregnant women. Next slide. This is information you can go to the CDC website to obtain, and I think that is it. I think the last slide might belong to Dr. Maldonado.
Okay, so we had a very ambitious agenda. We just have a couple of minutes left, and we do want to save a few minutes for any comments about vaccination in children. Grace, any comments there?
Oh, well, as many of you know, this week, ACIP approved the recommendation for vaccinating 12 to 15-year-olds with using the Pfizer-BioNTech vaccine. It's been a terrific, the data looked terrific, with 100% efficacy rate with confidence intervals, of course, but 0 cases in those who are vaccinated. And the safety profile looks very similar to what's been seen in adults. And in fact, the immunogenicity was certainly non-inferior. One might argue that it's even equivalent to slightly better, but I think the main point being that we're really excited. And I will just say that yesterday I took my 12 to 15-year-old to go get vaccinated, so I'm very confident in the safety and efficacy of these vaccines.
Well, there's a testimonial. This has been a whirlwind review. Bonnie, give us an idea about the future as we wrap up here.
Yeah, sure. I forgot about this slide, but yeah, this is what we all look for, right? What's going to happen next? And of course, it seems like some days are very head snapping days. We go one direction and all of a sudden, things are different. We saw that happen yesterday with the masking. We still have to take a deep breath and settle down and figure out what that's going to mean for us here in Santa Clara County, Monterey, San Mateo, all of the Bay Area counties, as well as California as a whole in the US. So in general, of course, nobody has a crystal ball. Mine is quite cloudy right now, so I can't really give you a perfect read of the future, but we're working on a number of strategies. So obviously, the epidemiologic data have been really important. I think the CDC, FDA, and other agencies have done a tremendous job in really helping us understand this pandemic. And I do think that we need to depend on our academic and providers as well to disseminate the message, because people are confused. They don't realize that this is what we do all the time, and that the data coming from the media are coming fast and furious, and people get confused. So just make sure that if you have questions, you go to aap.org, cdc.gov, or your own ACOG representatives. They are very good at interpreting the data and really providing so you can help people understand. In general, we're looking at therapies around monoclonal antibodies, anti-inflammatories, antivirals, and immunomodulator therapies. I've been overseeing a number of these for the NIH, the National Institutes of Health, and frankly, those are going to be slow trials, but we are making some progress in really stemming, especially the mortality from this disease. So that's been a big impact. We are also trying to figure out biomarkers to understand outcomes and who's sicker or who's at risk to become sicker or have complications. So those are studies that are ongoing. Those will take some time. You heard a lot about vaccines, but the big question that people bring up is, what about herd immunity? And I do think that it's important to talk about herd immunity, but it's really, herd immunity is all about your risk for becoming exposed. So the higher the herd immunity, the lower your risk, but it's not going to be zero until there is no virus. So there will be some degree of risk. And I think that's where we all need to have some judgment around what's the transmission rate in your community, what's the positivity rate in your community, and be mindful of that, because even at 70, 80% immunity in the population, you might be in a population that has that higher risk. So we just need to use some judicious common sense there. The degree and durability of immunity has yet to be determined. We know that natural infection provides about 3 months of protection, maybe a little bit longer, but we're seeing a lot of reinfections after 3 months after natural disease. Vaccine-induced immunity is not clear. Maybe we're hoping for a year. We're extremely hopeful for 2 years, but likely more like a year or so. And it does seem likely that we will need some boosters, and especially if variants pop up that are more resistant, we may need those. But fortunately, the vaccine companies are doing a very good job. Moderna can actually produce a new vaccine in 45 days, and Pfizer is not far behind, and the production is really the issue, is producing to scale. So then we're really faced with non-pharmacological interventions, which include masks and social distancing, and we just need to make sure we follow our local provider, our local county guidance. So in the long run, where do I think we're headed? I think that this may be an endemic virus that will pop up at some undefined period of time every year. It may be that we have a co-administration of vaccine with a flu vaccine down the line, but it may actually fade away. It certainly hasn't gone away like SARS did. SARS just disappeared from the face of the earth. That's likely not going to happen here, but it may actually become more attenuated over time as we vaccinate more and more people. So those are my predictions.
Bonnie, thanks. We're several minutes over. This has been just a wonderful expert view. I don't think we really have too much time for questions. So what we'll do is ask Valerie to announce how the questions will be answered. So thanks to the panel. We could have spent the whole 2 days on this topic. So thanks for condensing it and focusing so well. Valerie, how will questions be answered?
I want to thank everybody for their time today in the presentation. It was a great panel. I'm Valerie Cape at CMQCC. We will take the questions back to the planning committee and see if there's a way we can put together a document that can be distributed for everyone with those questions that did not get answered during our session today. I'm going to sign off for everyone for our midday break. And we will begin back at 12:50, right on time, with the next session on diversity, equity, and inclusion in perinatal health. So thank you for joining this morning. We'll see you at 12:50.
Thanks to all. Thank you, Bonnie, Grace, Christina. Bye-bye.